Pero necesita carácter.
15 people.
All right, it's okay. Chair, Honorable Dr. Baba, the advisor, colleagues, our PR, LFA, all our partners, welcome back to this session. As we all agreed earlier before lunch, that we reconvene at this time to look at the outcome of the PR consultation with the country team LFA on the final budget and what areas that are proposed to be revisited in order to balance with the available resources. We also had a consultation, as you know, among ourselves. The CCM has consulted the senior management of the MOH here, SAC, and the civil society on the same when it comes to the areas that needs to be reconsidered and bring or establish some efficiencies. We know that all what is being done will have to be completed today. At this point, I want to welcome everybody. Those that are still outside the room will join us as we start. So, Chair, with your permission, we can now allow the PR to start giving us the feedback of their consultation. Once that is done, we'll also listen to the country team on the other side, and then we pick from there. So, Karine, you can start. Thank you.
Yes, good afternoon, everyone. All protocols observed. Dr. Blaise has already given the update in terms of other areas that had been discussed to be reviewed, to identify efficiencies, to bring down the variance of 6 million. Now, in addition to those areas that were mentioned, there were also activities that have been discussed and have been recommended to be shifted to PAR. Now, these are the activities projected on the slide. We have 2 slides. The first activity is under the TB care and prevention module, and the activity is to procure equipment to scale up case-based electronic TB registers to health facilities providing TB services. This activity has been pushed to PAR. Currently, we have 31 facilities using the electronic TB register, while already using the electronic TB register, while we are in the process of course, the NTP is in the process of deploying or installing installing equipment at 4 health facilities. So the objective of the NFM grant was to scale up to 90 health facilities. So this activity has been recommended to go to PAR. Then the rest of the activities are under the prevention module. The first one is to undertake mass media campaigns using senior leadership and celebrities as condom promotion and behavior change champions through radio, meetings, and during the World AIDS Day campaigns. So this has been recommended to go to PAR. And then monthly stipends or incentives, transport refund, communication allowance to peer educators from the adolescents and young people in the military groups. We believe the military can be covered in terms of this activity. They can be covered by other partners such as PEPFAR. Adolescents and young people can be covered by other partners as well. So this activity has been recommended to move to PAR. The next activity is to design prevention programs for the military. Again, also this is, it's basically to provide TA to design this program for the military. including the validation workshop. So this is also recommended to move to PAR. The next activity is a combination of prevention programs for the military, production of materials at 100,000, also recommended to move to PAR. And then youth-specific condom promotion and behavior change dialogues at universities and colleges targeted at the youth at 48,000. And then quarterly condom promotion and behavior change dialogues amongst out-of-school youth in 50 targeted towns. Also, this has been recommended to move to PAR. Next slide, please. Hello, next slide. Oh, it's already there, okay. The next activity, support and utilize country-level football, basketball, netball tournaments to promote condom promotion, promote condom use and distribution. This has also been recommended to move to PAR. And then capacity development of youth networks, including training workshop for participants, 25 participants. And then the next activities recommended to move to PAR under the community system strengthening. The first one is targeted at supporting 7 FSWs from targeted locations and implementing organizations that support FSW activities to go for a benchmarking mission in Uganda. So this has been recommended to move to PAR. And then the next one is to support 7 AYPs PLHIV to benchmark also in a neighboring country, either Kenya or Uganda. And then the next activity is to equip, strengthen and equip one youth center in each of the 15 high-burden counties to provide safe space for adolescents and young people, to provide health education on the 3 diseases, SRH, and other health education. Then the next activity is to strengthen and equip one youth center in each of the 15 high-burden counties to provide safe space for health education. So basically this is the same activity. It has also been removed. Not removed, but shifted to PAR. So these are the activities that have been proposed to shift to PAR. The total budget for these activities is around 1.1 million. In addition to that, if you look at the detailed budget, you'll notice that there are other activities that have been that have not been shifted to PAR to support the youth networks. There is 3 budget lines for capacity development for youth networks, including TA, production of materials, and supporting youth projects. And then development and dissemination of national peer education training curriculum for HIV/AIDS, and then training of new and existing peer educators on combination prevention messages. And then there is also population-specific capacity building workshops targeting FSWs, AYPs, PLHIV, and so forth. And then there is also an activity to strengthen linkages with women or girls friendly services or spaces to enhance community-level access to GBV support services. So, you know, these activities have been recommended to move to PAR, but there are other activities that have not been recommended, that have remained within allocation. So this is it for my presentation. Thank you. Maybe you can just project the first slide.
So this is the first part of the presentation, right?
1.1 million.
Yeah.
Yes.
1.1 million.
Yes.
And this is the
relates
first
to
part of the presentation.
Specific activities.
Yeah, the list of the activities recommended to move to PAR.
Yes, correct.
Okay.
Yes.
Thank you, Karen. Overall, yeah. Budget, yeah, no.
Okay, the budget. Okay.
$1.1, I think this one. Yeah.
Yes, it's 1.1.
Let's see the budget.
Okay. Okay, can you please shift to the other screen? Yes, I've projected it. I've shared the screen on the Zoom, so they need to project that screen. Okay. Sorry, how do I do this now? Minimize.
It's okay.
The Zoom panel on your
Okay.
right.
The modules. Okay, that is. This is the summary by module. Okay, second slide. This one. Yes, I think the naming is incorrect, but this is yes, this is by module. Yes. Yes, it's not cost input.
So you can take us through, or someone to make a comment on that.
Okay. According to the latest update, after the budget was updated with in terms of moving the activities that I've just presented to PAR. Right now, this is what the budget looks like. The summary budget looks like by module. Treatment care and support. The budget is currently at 31 million. Program management, 16 million. TB care and prevention, 9 million. Differentiated testing services, 5.8 million. MDR TB, 2.9 million. RSSH Health Products Management Systems, 2.9 million. RSSH HMIS, 1.5 million. Prevention, 1.4 million. Community Systems Strengthening, 1.2 million. PMTCT, 1.1 million. Laboratory Systems, 1 million. Reducing Human Rights Related Barriers, 451. TB HIV, 272. RSSH Human Resource for Health, including community health workers, 138,000. So the total budget currently stands at 76 million. So there's a variance of 4.8 million that still needs to be adjusted in order to reach the 71.5 million. So this is what the summary budget looks like in terms of modules at the moment.
Thank you, Karine. Just to add, thank you, Chair. As you can see, this comparison between per module between the funding request and the grant making, there has been a lot of homework that was done since 2 weeks ago to try to bring, to try to accommodate the commodities, right? So as per my feedback that I provide to you this morning, we discussed with the country office and then the country team, and we went line by line, and they provided the guidance on the activities that can be moved to PAR. And I said to the country team that this is the responsibility of the CCM to make that decision. And Karine presented the detailed activities. And this table is just summarizing the situation after those activities and other activities were actually put back into the main allocation. As you can see, initially the treatment, care, and support was 23 million, and now is 31 million. So that 7 million came from PAR, right? The same for TB care and prevention, 1.7 million came from PAR. So this is really the last effort that we can do to accommodate the commodities. Now, 2 issues. One, we are assuming that the activities that we push to PAR will be taken care of by PEPFAR. And PEPFAR is not here to commit to that. So someone needs to give the guarantee that this activity will be implemented, despite that they are not under main allocation. That one. 2, this will have an impact on the SR. We presented the SR selection yesterday, and they actually bid it by module, and it was based on the first column of funding request. Now that most of the activities are moved to PAR, about 4.8 million is moved to PAR. So you can imagine that it will have an impact on the SRs. Some SRs will become irrelevant. So that also need to be discussed here. And this is the right forum to discuss those kind of things. So as you can see, a big effort has been made to reduce the program management. And that is really the maximum effort that can be done, and the details are provided to the country team. So that's what I had to add, Madam Chair. Thank you.
Thank you, Dr. Blaise. Thank you, Karine, for the presentation and all the team for the work. Chair, I think, anyway, from my own perspective, I can see that there is a progress. We are now 4.8 million above the ceiling compared to 6 million above the ceiling. So we are coming. And Karim, before you leave, with this, we will definitely go back to the slide that you have shown earlier. Or you can still project it from where you are. The proposed activities. Is there, okay. Yeah, so looking at this picture now, we are actually a step ahead from where we were this morning. So we are still to look for how to accommodate the 4.8 in the allocation. Of course, to cover them so that they go to the above allocation. Now, if you can go back to the slide of the proposed activities. Well, as we wait for the slides, we have seen it, and to me, the proposed activities are lighter activities. It's only that they are significantly a good number. But again, if you can see by module, they are mainly in 3 modules. There's another slide next. These are 2 modules. Then there is RSSH. Go back. What I want to say, the proposal here, as Dr. Blaise said, the understanding has been if these activities are also covered, or not necessarily them, but these modules, PEFA is also investing in them. I mentioned earlier that looking at the resource comparison between PEFA and the Global Fund, there you can see some information about the allocation that PEFA is putting into each module. PEFA is investing in HIV prevention, and definitely it would be good for us to also open a discussion with the PEFA, and I understand PEFA guys are online. They can also tell us straight away some of these activities that if they can be covered, because you also know that PEFA has activities for the youth, has activities with the military, has activities for the support towards the RSSH. The only challenge I can see here now straight away is TB care and prevention, which is not supported by PEFA, you know. So that's straight away we can see the 90,000. So the assumption that PEFA will support that will not hold water, and we all know that. But I can see, yeah. And that one is a small amount, you know. So my advice and my recommendation is, let's get a comment from PEFA, and then we move on. I also know that these areas of even TA, whatever, that is much of what PEFA is putting money into as well, you know. In many occasions when we discuss and we talk, there's a lot of investment that they are putting into TAs. So I believe they can consider this. The other slide, as I mentioned, is about the health system strengthening. Can you show the second slide? Yeah, because the rest are actually under the prevention. Here is institutional capacity, planning and leadership development, and is mostly towards the community system strengthening. And I think both are trying to support the communities. In any case, I would appreciate if PEPFAR could also, in a way, look into this. Or after all, taking them to the above allocation is something that I can understand. Now, with all this, it's actually giving us only 1 million. Not so, it was said to be 1.1, not so. But if you also be mindful of TB and treatment and care is not going to be covered by any other partner, then you talk of 1 million, roughly. Are we together? Which is not yet considered in the summary you have shown by module. So that 1 million can still come out from the 4 million. How comes? These ones, you have not yet deducted them from the budget. It's deducted, that's the bad news. I thought now the exercise you did on the other areas with the PR. No, I was saying they have already been deducted. Yeah, I thought they were not yet deducted because the decision is not taken. Okay.
Deducted from
It's
the
deducted now, we're
understanding,
still
yeah.
at 4.8. All right, fine. Here, we remain with the bigger question.
Yeah.
Where are we going to get 4.8?
5.8 actually.
It's 4.8.
4.8, yeah.
Yes,
We were
four-
assuming 3.8. 4.8,
Yeah, now it's 4.8. Let's go back to what we discussed in the room when the PR was not with us and the country team was not there. Our discussion was considering some areas which we would want to ask the PR whether they are also considered in regards to the modules. We have talked about the MDR module, the targets and the treatment, the transition to the oral treatment. All right. It's good that we do next. In principle, what we agreed yesterday, we are taking this with the full understanding that we go as much as we can do with the activities, but in the same time, let's also, if we are not getting anywhere, we can still revisit and see what else can we do. Yeah. Honestly speaking, the areas that are, bringing the bigger change here are the treatment and care, the HTS, and to some extent we have also identified in our discussion some areas under the MDR module, MDR TB, whereby if we can also do a slight adjustment in the targets, as well as the ART targets and the corresponding testing commodities, we can come somewhere.
Yeah.
The rough analysis we did, Emmanuel, was taking us to something around 4 million.
Yeah, it comes to this line, and this is just all estimates.
Yeah, it comes to about 4 million. So can we also try to see how can that be also presented here? And share also with the country team.
Okay.
One chair, if you can also.
They already want, they want to make comments. I think as Emmanuel is maybe preparing something that we can share, can we hear from Job?
Thank you, Madam Chair. Thank you for what has been presented. Can you hear me?
Yeah, we can hear you. Job, are you there? Are you there, Job? I think he's disconnected. Maybe. He's disconnected, right? From his side, okay. Who else is there online? I saw Godwin.
It's appearing online. Job is appearing.
See this?
Online. Oh, just disappeared.
Who else is it? They've raised their hands?
Yeah, Jane, this is me here.
Yes, John.
I wanted to make a comment on the TB care and prevention, and Chidende also, I think, almost answered. He actually hinted on what I wanted to say. Now for PEPFAR, no, it only funds HIV programs, so anything to do with the TB may not be funded by PEPFAR. But on the prevention component, especially the behavioral change component, PEPFAR actually has shifted away from there. I think for the last 4 or 5 years, there's been no funding for that. So it's a bit worrying if we see, especially the youth here, the young people, if the program is affecting them so much, but anyway, it's not being removed, but being pushed to above site, it is likely that PEPFAR is actually not going to support this. And also, if Global Fund is not putting resources, then it means the youth are going to miss out on this programming. But one thing that maybe sounds like youth is the DREAMS program. And as we said on the first day, the DREAMS program is only in Juba. And that's why they are going to work with the adolescents and the young women mostly. So if we are cutting out most of these youth programs, it will look like our young, active people are going to miss out in terms of behavioral change programs. Over.
Thank you, John, for making that clarification. I think let's listen to Job. He's online. Yes, Job. Are you online?
Okay, so, Dr. Jen.
Yes, please, we can hear you. Go ahead.
Okay, this is Patrick. I just want, while we're waiting for Job to reconnect, I just want to make one quick comment on the both on the TB, on the item of TB that was mentioned there, and maybe a little bit about the youth program. Okay. So on the TB, I think we need to look at the actual activity. What's happening is this a patient managed, what is it, the ETBL. It was kind of a software thing, and it's only affecting a few, it's to be implemented in a few facilities. And we actually suggested that the program, the ministry needs to discuss with NTP how to take forward that, because there is directive from Dr. Lako in terms of the aggregate reporting. We are going to use the DHIS too. But the ETB management is for case, I think it's for case management, but it's not fully scaled up. The proposal here was to scale it up to 31 facilities. And we know that we have lots of facilities. So there's an element there. And then, so it can't be used, it's not being used across the board. It would be used, I don't know whether it's by one SR. It was not clear basically. And the other thing to think about it that the ministry needs to take on board is whether the current situation is scalable, because we are talking about a custom software that depends on an individual to go around and update it, and whether we want to take that one forward. But in terms of reporting, we understand that the TB, the DHIS has been upgraded to support the reporting from the facility level, and we are fully supportive of that activity. So that's why we said for this particular activity, there is some missing clarity, and therefore this can go to PAL until there was an element, there was an additional amount for TA. We left that one in so that the NTP can have some consultation and technical advice on what they want to take forward in terms of the ETB manager and the DHS too. In terms of the youth program, these are very important, as we already know, but these were few specific activities and you can actually see the amount. And the fact that PEFA, at the beginning we've been talking about the complementarity of the two programs on different geographical parts of the country, and PEFA is taking it on the other side. So as an aspect of that, we were saying, I think there was a rationalization of those expenses and some of those expenses that PEFA needs to look at, because like you've been saying, let's say PEFA is working on this and the Global Fund is supporting, in addition to the commodities, is supporting activities on this other part of the country. So you could see, for example, those activities are mentioning in each of the 15 high burden countries. Do this in the 15 high burden counties, which we know is entirely the focus of PEFA. So that's why we said that. There was also the condom promotion. One of the suggestions we said, and I think this is a suggestion that the CCM can take on board and the ministry, because this grant is not procuring any condoms. I think we need to engage further with UNFPA to see that since UNFPA is procuring all the condoms, there's an additional cost that is needed for condom promotion. And we are proposing that the CCM, the ministry can engage with them to see if they can take aspects of some of those costs. Yeah. So yeah, and then in terms of the pilot that John Mondi mentioned about, so for example, support the adolescent young population for benchmarking. That sort of exercise is more closely linked to the pilot they want to do than what is being funded on this other side. So it's actually more appropriate. It should be taken within that context to see whether it can fit in. Thank you.
Okay, Patrick.
Chair.
Thank you.
Chair. Thank you, Patrick. What we want to say here, for those who will comment later. Yes, Job. We want to say, those ones now that are on the screen, we do not see any need for much discussion and spending time on it. Let's accept them, and we want, the most important thing now is what next, because we still have 4.8 that needs to be covered. Let's accept that this is what has been done so far, and let's not waste more time giving justification to this. Engagement with PEFA, with UNFPA, with other actors, we can still do it as CCM and MOH afterwards, and we need to move forward. Chair.
Thank you. Job, let's hear from you. I hope you are connected this time.
Yeah, I'm sorry for the technical problem, really. So quickly, thank you to the team for this. And I guess we are much in alignment with what has been presented. To me, I feel like, however, this is just one side of what has been discussed. There is a bigger side of even this budget that we've touched base with the PR, and they know very well what I'm talking about here. And this is the program management cost and the HR costs. We are very much aware that there has been significant increments in HR costs outside the scope of what has been approved in the current grant. And there will have to be efficiencies from there, because I don't really foresee how we will have additional HR beyond what was approved, and even rationalizing whatever other indirect costs at the PR level that have increased. And those are things also we've already discussed with the PR, and we'll be getting there. So if going forward means looking at the 4.8, there has to be that very clear understanding that we are not just looking at 4.8 in isolation, but there is a lot of other costs that we've already discussed with the PR. I really wished Dr. Blaise can speak to that, because I expected them to share that. But it seems like some details have been missed here. The discussion we had was much broader than just the activities. So over to you, Dr. Blaise, not unless something has changed. I don't understand.
Thank you.
Chair, can I?
Yeah, please go on.
Thank you, Chair. Job, I think it was very clear, the discussion that we had, right, regarding the HR and management cost. And we did it, right? Job, we shared with you the detail for the PMU cost, right? As you can see, there is 1.7 million that resulted into reduction of the management cost, right? So the principle that we agreed are these. For the UNDP PR, there is no change into the HR. We only added one national position for RSSH, that one. 2, for the ministry, for SAC, for the incentives, ministry, I mean HIV program, TB program, National Reference Laboratory, and Blood Bank. We comply with the letter that was addressed to the CCM last year, or 2018, I don't remember. The same position that was approved by the Global Fund will be the same position that will remain there. There is no change. For the incentives, for the staff in the sites, the understanding is where PEPFAR is working, we don't pay incentives there. But in the sites that are not supported by PEPFAR, we continue pay incentives. We can't expect much reduction further beyond this. We should not go around the cycle. Let's be practical. We said there were 3 options. One, we go through the activities and we get savings through the activities. What we have done this morning, and you just approved the activities that will go to PAR. And that was done with LFA and country team. So it doesn't cover the 6 million gap. It covers only 1.1 million. The second option was to go to revisit the target. And the third option was the combination of the 2, activities and targets, which actually is the remaining only option. We went through the activities. We should now go through the targets and revisit the targets to cover the 4.8 million. And my understanding is this meeting, you actually did a homework on that. And it will be good, as much as we just took you into what we were doing when we met with the Global Fund and the country team, the country team and the LFA. If you can do the same for the appreciation of the country team and a consensus between us here, if you can take us through the exercise that you did regarding the target, and we see whether the savings can cover the 4.8 million. Chair, that is my proposal.
Okay, thank you, Dr. Blaise. And I think that's actually, our thinking, that we just listen to the presentation and then maybe some quick comments from the country team. But we also want to share with the country team, although the initial summary was done earlier, maybe some of them were not online. But maybe we'll also share the discussions, we had, as you were. There's nothing they will comment.
Just before you go on, Madam Chair, with your permission, please. I know the letter you're referring to, Dr. Blaise, it refers to the current grant. In as much as whatever commitments are contained therein are binding within the current grant, there is no guarantee whatsoever that they will be honored. Some of these can easily be renegotiated, and you understand that very well. So some of them, of course, we are flexible around renegotiating and sustaining, but you need not carry over that guarantee into the next scope, because that is not yet signed against. So, and that's how it is. Even this grant, it's not cast in stone yet. It's way far away from getting approved. My call again, Dr. Blaise, you understand very well what I mean when I say we went through HR costs, which include those at the PR and the programs, incentives, and otherwise, that we clearly, and we can go through that list again, and there'll be efficiencies there. I don't think going to targets right now is the last result, is what we should be doing. To me, revisiting the targets is no doubt the option of last result. If you want us to do that, we can do it now. But as I said, there is more to those figures than just what we see here. We can revisit it, we can go through it before this document is approved, but we should not disregard that discussion just because of, for the sake of it, if I would say that. So maybe it's up to you now, but I know then if that's the route we take, it might really entail a lot of back and forth, which might not be very needful.
Job, thank you, but with all due respect, I don't think you can find 4.8 million elsewhere. You can't. It's really impossible. You talked about the indirect cost. The indirect cost fee is fixed, is known. There is no way you can go above or beyond. So 4.8 million, if you don't touch to the targets, forget about the grant. It's the only option that is left. Whatever saving you can make, you can't get to 4.8 million.
Thank you, Blaise. I think, Job, if you can just also listen to us. We also had, as we were waiting for the PR and yourselves when you were consulting earlier, we I think CCM and with the ministry senior management here as well, we also had some, discussion and share also what our thinking is around this. So maybe I will just request Dr. Kidende and Emmanuel just to share, some of those points that we have tackled, and then together we can see how we can move forward. So you can start some of the areas that we also looked at, and then Emmanuel can.
Thank you. Chair, you are right, and in this meeting we expect it actually to come and go a step forward, not to go back. What the PR and the country team has done, to my understanding now, before I go to what we did, Dr. Blaise, the consultation that you people had rested mostly on the program management and proposal of those activities that can go to PAR, which you have just shared here. And from each of the two, you have made some efficiencies or some things that can yeah. So I can see that from the program management, you said you have reached 1.7, 1.7 million from the program management. And then from the activities that were proposed here, is going to be, it was 1.1, but it's going to be 1 because the TB part will not. But even say 1.1, it's okay. So we now come to 2.8, which no, I'm talking of the saving, the efficiencies that the amount that you have reached from this. Yeah, because I actually want that clarity from the program management. The efficiencies that you have achieved, how much is it? 1.7. And the activities, you combine the two will be how much? This is what I was saying. That you have now, which is a step forward. That's what brought it back from 6 to 4.8. No. Yes. You have increased the. Is that the case? from what was there. Because we expected you to get efficiencies and to reduce. You went and increased.
You are mixing things. Yeah. Because look at the
Where is that slide?
Please, can you project those slides with the figures, huh? The allocations? The allocation and the grant making.
Yeah, because Dr.
The
Blaise, for us, we are starting from where we stopped when you left us. The slide that we had.
With the 6.8 million.
Otherwise, you explain what has happened so that we can also understand in other areas.
The slide on the module. Yes. Where is the slide on the module? Huh? So the slide on the module. So the 1.1 from the activities is distributed into these. Huh? So you can't determine that 1.1 is from here. It's distributed into this module. Okay, but program management is 1.7. Is 1.7, but even last time. Distributed, yeah. Last time it was. This is the last 1.1. It was actually,
the program management was 18.5. Yes. Originally it was 18. Now it has come down to 16.
Yes.
Yeah, that's what we are saying.
Yeah.
We have made some.
Yes.
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 Then we are saying a module on the TB, the TB care and prevention, was 6.9. And now it has come to how much? It's now 9.
It was the funding request was 7.5.
Not funding request. The slide you gave us before you went, when we had 6.911 as a gap. That module was 6.9, was 6 something.
Was 6.9113.
Yes.
So it has increased. That's what we want to understand, because you are testing it. Then why? But you just tell us, why has it increased? Is it about the targets? Did you, and you said you did not have, what increased it?
Sometimes there is a wrong classification.
Okay, then that's what we want to understand, to appreciate. First, this was not the figure. Now the figure has gone up. Then we definitely will ask why. Then you tell us this is what has happened. It's fine. It's okay. No, it's all right. It's fine. So it's all right. It's okay. It's fine. So now, Chair, what we are seeing here in the total budget, the gap has reduced from 6 million to 4.8 million. We are saying, based on our own consultation here in the room, we have looked at the targets. As Job is saying, well, we also agree that is the last resort. And for us, if we have really reached the extreme, then it is now the time for us to also look at that, knowing that 4.8 million, there is no single module here that can give us 4.8 million. That's the reality, and we have to be realistic as well. What we did earlier, the country team, and it's good that we have Job and Patrick as well. We try to discuss and revisit the targets in the sense that if we look at the baseline, the TRP has mentioned 2 options for us to stem from in the comments, the 2019 and June 2020. And the application has indicated 40 million as the baseline, which has considered something like 35,000 people on treatment by 2019 December. Now, If we take that as the baseline and we look at how we have been moving, we will get to 2021, by the end of 2021, at around 47 rather than 48,000. And from there, if you also add at the same rate, if we are just maintaining the same performance, not declining, definitely we come by the end of 2022 to about 52,000 rather than 55,000, which we really indicated. You also add the same, which is 6,000, the performance annually. Then we will come to about 58 or 59,000 by the year 2023. We are actually mindful of the fractions there, so it can be around 58, 59 by year 3. If we consider this, in the total by year 3 or whatever that we have reduced, we'll come down from 63 to 59. That is by itself 4,000. And then for year 2, we'll see that we have come down by 3,000. Year 1 is actually by around 1,000. If we combine all this, it takes us to something around 8,000. The corresponding cost for putting 8,000 people on treatment, as well as the testing cost for that number, was estimated, and we actually have our PSM focal point, or chair of the PSM subcommittee here, Dr. Emmanuel, will help us, because he also immediately did some rough calculation, and it indicated how much saving will be reaching there to cover the gap. We also look at the MDR-TB, both the targets as well as the treatment options that are there. And I remember, Job, yesterday you mentioned that we even consulted with the Godwin, and definitely also came to the point that we, as much as we need to transition to the WHO recommendation, we as a country have the right to face this. And that we came to a conclusion that we can do this gradually, and we can do that from year 2 onwards, and continue with what is available on injectables for the MDR for 2021. The MDR targets themselves, we look at the baseline. This year, up to June, we had only 37. And we try to project by the end of this year, we might be around 70. To come to 120 by year 2021, which is 27% of the 447, which was the denominator, was seen also somehow ambitious, given the operational challenges that are still there, despite the fact that, you know, the equipments and everything are there being put in the field. We have been going to the field and we have seen what is happening. So we said let's be a bit rational, and we talk of 22% rather than 27%, and that will be 100 for 2021 instead of 120. For 2022, we will come to 30%, which is an increment of 8%, which is actually year 2022. Then we come to the third year, which is the last year, at another increment of 8% above what we achieved in the previous year. We'll come to around 250. Year 2 will be 160. So it will be 100, 160, and 250. We are making a bigger shift. We are becoming more ambitious as we move, and we expect the operational issues for the case detection when it comes to the MDR will definitely improve. We know this is the target that we have not, one of the major targets that we have not been doing very well at, and we are still, mindful of the challenges that are around this. So considering all this and the corresponding cost and the saving that we can get from the treatment aspect, as well as revisiting the targets, we come down to a saving that is closer to 4 million, honestly speaking. And we believe this is actually the most reasonable thing that we can, or the best option that we are left with now, given the fact that 4.8 million, we all know is going to be very difficult to find it from a single aspect or one module in this regards. At this point, Chair, I can give Emmanuel to add more inputs on this.
Anthony, let me email you the updated one.
Excuse me, can you help us switch on the AC? Please, yeah, thank you.
Do I need to stand there or I can do it from here? Okay, cool.
Stand up, but just use
Good afternoon, ladies and gentlemen. Thank you. Assalamu alaikum, Nas fil Juba, and greetings to all our other colleagues everywhere. Tough times call for tough decisions, and we're running out of time, so we may have to see on how the best way to go forward. Anthony, when you're ready. To review, just a quick topping up on what Dr. Kidende mentioned and also adding up on some of the numbers that we've discussed. There are two things that we discussed mainly. It's actually reviewing the targets first of the TB program, the HIV program, and then after that, looking at the TB program, also the targets, and as well as the treatment modules for the TB MRTB, as per recommendations by the WHO. Now, technically, this is what we had. Actually, it's a wrong one. It should be HIV, not TB. That's the approximate targets we have. We're supposed to run 2021, we have 47,720. 2022, 56720. 2023, 63720. These are the people actually we plan to have under treatment all through by the end of these corresponding years. Next. If you have a look at the baselines, and I took out the 720 out of it, the previous one was based on an increase of about 7,000 people. By adjusting the baseline as per the June 2020 details, where we had between January to end of June, we had about 3,000 people who actually enlisted into the program, who actually enrolled. So using the same estimates, that means that between July and December, that's an extra another 3,000. So we're looking at about an increase of about 6,000 people per annum. Going on the same aspect, and if we run from there, let's say the estimate is about from 35,000, which is the 2019 results, end of 2019. By the end of 2020, this year, we should be having 41,000. Correspondingly, if we go to 2021, the number will actually go up to 47,000, then 53,000, and ultimately 59,000. Now, if you go back the slide before, Anthony, go one back, you will see that there's gradual decreases in the number of people who will be under treatment all through. So from 47,000, it will go down to 46, and then vice versa all through. Next. The gross cumulative reduction of the number of people under treatment based on the two baselines will come to approximately 11,160 people over the period of the grant. So we'll have actually 11,000 people less going under treatment. Depends on which baseline you use. Now this equates to about 6.5% less people, if you compare everything, the total number of the first initial grant of the first baseline and the second baseline. So the 6.5% decrease in people will actually have a big impact on the cost of treatment and the HTS services. Next. Now, quick calculations based on details that were shared by the finance department from UNDP. I believe it was Honorable Mizo from Japan. Hold on, let me just turn my computer on. I like going with figures, but these are details that were shared this morning from the review done by Mizo. Looking at that, and we're doing as a gross, okay? So we haven't really gone into the real details to separate items with, line by line within the corresponding budgets. So when coming to treatment and support, the total for treatment and support, which covers 40% of the entire budget, it comes to 30,900,000 estimate. If we take the 6.5% reduction in that total gross amount, will be the equivalent of about 2 million. If we go to the HTS aspect, because we're actually expecting 11,000 people less coming into the lifeline of the budget, HTS accounts for 5,885,000 approximately US dollars. Now, a reduction of 6.5% comes to $380,000. That gives us a gross total of about 2.4 million, give or take a few details here and there, if we were to review the details properly. Now, that will be about half of what exactly is currently missing. I mean, that will take about half of the chunk from the 4.8 million, depending on also how we do the baseline. The baseline can still be reclarified further to reduce this one, or rather to increase the amount that we can be making saving from. Next, TB. Okay. Now, going forward to the TB program, one of the biggest challenges we've had, and is also the management of the TB, the MDR-TB, and there's a transition as per the WHO guidelines to move away from injectables to oral drugs. And the main reason is that the oral medicines do have a better adherence in terms of with the patients, which is actually a good thing. But at the same time, when we're looking at all these items, the two main drugs being recommended for TB program is actually delaminate and bedaraquine tablets. These are really, really, really expensive. Now, what we're actually saying, the recommendation of the two drugs, which includes delaminate and bedaquiline, if I look back at the TB program, which it's not on this slide, but it's actually the HPMT for the TB narrative, the first drug, which is the delaminate, accounts for about 80% of the budget for the TB treatment. The second drug, which is bedaquiline, accounts for, I think, almost 5% of the entire items altogether. One of the biggest problems is the cost. The cost of these items are quite high. The delaminate estimate is about $1,700 per dose, while the go back. Yeah, just leave it. Just go there. Just stay there. Yes, the delaminate costs about $1,700 per dose, and we are requesting for about 939 doses. Without compromising too much, there's two options we can go for. Now, the first option I wanted to look at is, without compromising too much in the issue of changing the program too drastically, first option, we can actually decide to say, for the first year, we continue with the injectables and we don't procure anything and we procure less of delaminate. But later on during lunchtime, which I never discussed, I was doing some calculations, and it's possible to actually reduce the cost of the delaminate medicines, reduce the quantity. Say if we were to bring it down from 939 doses to 239 doses, and instead we used the same savings to purchase a similar number, 700 doses of bedaquiline tablets. This will actually, because one course of the delaminate is about 4.25 courses of bedaquiline. So just making the small switch in our regime programs, which is as per the guidelines of the WHO guidelines. There are 3 different regimes, treatment regimes which can be used. If we use a bedaquiline-based treatment, instead of focusing more on a delaminide-based treatment, we can always maintain the same number of courses of oral medicines, yet manage to get about a 900,000 savings out of that, without compromising one on quality, but at the same time, we can still have both on target. We just increase the quantity of one item more than the other, which will mean changing focus on how the HPMT was done, and it may have to switch to a more bedaquiline infused, heavier, whatever, treatment guide. The only compromise will be that the treatment term will be a bit longer with bedaquiline compared to delaminide. But we'll still be making some savings in the long run. And we'll still have both medicines in the pipeline, as well as other injectables, without compromising on the number of, on the quantity that we actually required almost all through. Putting these 2 together, I think we can make about 900,000 plus 2.4 million. That should bring to about 3.3. This is just a quick rough estimate. But then, of course, it's open for debate, and we have to see ways and means of how to reduce this. I know, of course, the TB program people will be coming after my neck, but for the quick guessworks. But it's something we can discuss once we get back to Juba. Thanks.
That's all, or you have?
Thanks. The total. We need, I think is the last slide. 3.3. Yeah, it comes to about 3.3. It's practically 2.4 from the HIV side and about 900,000 from the TB side, just focusing on MDR TB. But we haven't even changed the targets for the TB, by the way, just by focusing and changing the regime treatment, the treatment regime, actually.
Yeah.
Yeah.
Okay. Thank you, Dr. Emmanuel, for that presentation. Job, are you still there?
I'm still very much here, Madam Chair.
Oh, okay. I hope you have listened to Dr. Kidende and Emmanuel. And in fact, this is actually, this has been the areas that we have been thinking, we have been sharing and deliberating on, that these are the last resort, that if we are not able, if we have to really make decisions and find that saving, which now is at 4.8, these are the lines that we need to be thinking, towards or discuss or look into these to be able to make that saving. So I don't know if my team here, they have any additions to make, but otherwise, these are the areas that, we think we can revisit. I know you have said the targets should be the last, but I think these are the areas. This is one of the things, we have looked at. And, we can see that there is an opportunity for us to, to make some savings, if we try to look and analyze it this way. So I don't know, it will be good also to hear from you, if this is the direction as we are saying, we think this is the direction we should be taking now, to look at this. That's our recommendation, as a country we have had the PR, but this is also as CCM, this is where we have been looking at, that these are potential areas that we can revisit and maybe make some savings.
Chair.
Thank you very much.
Job,
yes, please.
Before you come in, on the same note, Emmanuel is still updating. Actually on TB side, what he has just illustrated is when we look at the treatment component. But you remember I also mentioned when we also revisit the MDR targets, in the sense that we start from 22% from 2021 and increase by 8% up to 2022 and 2023 to have 38%. This will also result in more savings. And he's still updating, and you will even see. We will actually end up having more saving than what we have just shared now. Thank you. Back to you.
Thank you, Dr. K. Thank you, Madam Chair. Thank you, Emmanuel, for the detailed presentation. We've really made a lot of progress. It wasn't meant to be an easy task. It wasn't meant to be an easy journey. As I said, grant making sessions are never this easy. It's all that it entails and all that it is expected to be. At this point, I can't really say much beyond a lot of what we've been talking about. You all very much know we are a partnership-driven organization. The institution is founded on 4 principles, which is partnership, transparency, performance-based funding, and country ownership. One can never be elevated above the other because they all supposed to work hand in hand. I really very much appreciate the leadership of the CCM. I think also Patrick mentioned this, was the first one to mention that actually the program belongs to the country and we are just there to fill the gaps and support to the extent that we can. We are not trying to create a parallel system, neither are we trying to create a country within a country and run it as a program. So we see where we want to go and we know what it takes. As it pertains to the targets, I still strongly believe before we get there, we will have to come through the budget, align what needs to be aligned as far as all the assumptions are concerned. I specifically mentioned the HR issue. It's what it is. It can't go above where it is right now, and that has to be clearly understood. And if that can be exhausted, we will very gladly look at also the proposals that have been made. Thanks a lot, Emmanuel. The proposals around TB, well appreciated, and the many others that you've mentioned, and also what Dr. K took us through. I believe those steps will lead us somewhere. At this point in time, we can't cast it yet in stone yet. I strongly believe, as I have said, we need to look at all the other assumptions, and this is the work that LFA is there to help us to do, and that the PR team also has already done this several times, and they know what I mean. So we will just go through that process, and then when that, because even all these figures we're seeing here, 4.8, we need to go behind and see again, as I said, because we were looking at the detailed budget before we came here. So after that process is finalized, we can then see what would be the way, the outcome of that. Back to analogies here, we are not saying that this baby is not gonna survive. I know the baby is alive, the baby has been born, there has been a lot of care taken to make sure the baby is delivered alive. We are not going to kill the baby. We just want to make sure the baby is well clothed and well nourished. At some point, maybe we can't buy new clothes for the baby. The baby might get clothes from the siblings, but it doesn't mean the baby will not be alive and kicking. We might take exclusive breastfeeding route for sustainability and not buy, artificial milk. So these are the type of scenarios I'm talking about. I know ultimately we need a product, and that product we will get it. And the product we will get is a product that we can defend to the very end, defend before the GAC and all the other stakeholders who are interested to know what we are presenting and what is the direction of the program. This is all I can say for now, and I believe in the next few hours or whatever time it takes, we will have that last document. Thank you very much, and over to you.
Thank you, Job, and thank you for that beautiful remarks, Truly, a baby is born, and I think we need to do all possible to ensure that that baby survives and grow up, at least up to a toddler age of 3 years. Thank you. I think, David, we have David from LFA online.
Thank you, Madam Chair. I just want to point out that when we are talking of the targets, we need to bear the following issues in mind. For end June, we had 38,460 people current on ART. However, we also had 10 facilities that never reported, because this was the first period when we had data from DHIS2. And the DHIS2 was not able to capture data from 10 facilities. And those 10 facilities in December had reported 1,039 clients on ART. Also, out of the DHIS2 data which was captured, 7 sites actually reported a reduction of 2,452. So there is a risk that there was underreporting. And that underreporting is likely to have accounted for almost 3,500 people on ART. As we go into the grant making, we also need to know, as we go into the new grant, we also need to know that, this grant, its implementation has taken place almost throughout when we are having a military crisis. Now that we have hope that stability is returning, we are likely to see increased access to services. At the same time, we're also talking of interventions by PEPFAR, which are going to focus on the issues of quality at the facility level, which are also going to focus on retention to care and loss to follow-up as well. So these are likely to generate more people being cared for on Earth. So when we are setting our targets, we need to be very careful to ensure that we are not going to face issues of stock out of drugs because of underestimation of our targets, which inform the quantification. So I'm very optimistic that come December 2021, would have hit at least 48,000 people in ART. Thank you, Madam Chair.
Thank you, David. Kidenda, you want to make a comment response to that?
Thank you, Chair, and thank you, Job. I actually want to go back to Job, but before that, I want to reassure David that we are actually mindful of all what you have actually outlined. And please be rest assured, whatever targets or whatever actuals that we'll get by actually comes 2021, we will not have any stock out, because at that time we will still have commodities as the grant is running. Since it is a 3-year grant, it will just be a matter of how are we going to plan for the commodities. The other thing is, whatever we are removing here is not being thrown away, it's put into the buffer location, with the understanding that the buffer location will stand 2 chances. A chance of a reprogramming that might really take place, and we have always been doing this exercise after a year or so from the implementation. That's an opportunity that is there. Plus an opportunity of the portfolio optimization, if at all it happens. Whatever that goes to the buffer location here, the commodities, of course, will also rank high in the priority within the PAR. So we are in a situation whereby we are to make tough decisions. And I also want to recommend, Madam Chair, going forward, let's make comment and also make suggestions. Otherwise we'll just be dwelling on, comments and comments and comments, and we're not going anywhere. We are against a fixed situation that we must find solution before the day ends today. So please, whoever that is going to comment afterwards, give us also what you think can take us out of this. Coming to Job, I really appreciate, the country team's comment on this. And I want to also come back to the principle when we agreed to revisit the targets upwards. We mentioned the principle that it is going to depend on the available resources. Our ambitious targets will still be there, and indeed we are ambitious. As I mentioned earlier, even if we go by what we are just saying, and the updated calculation that will come from Emmanuel very soon, we will not actually identify the 4.8 million. So what we wanted to do is to be strategic enough and make use of our time. Something that we are seeing is not like what we are just imagining. So definitely, if we consider that whatever additional saving that we'll get from the calculation that is being done now by Emmanuel may not still go beyond 3 or 3.5, and we know the gap that we have been talking about. So definitely, if I take the savings that have resulted from your consultation with the PR, plus what we are also now proposing here, looking into the targets, there is still a slight gap, which will still require the PR to go back and revisit all those other areas. We know the areas of HR job are actually very, very crucial here. And we have already been going through a lot of pressure, even from other partners, including PEPFAR, that we are not adequately supporting the program implementers. And I can believe them to some extent, because the moment we started to get the flexibility under the current grant, we have also seen a significant improvement in the performance, And that, of course, is what we discussed yesterday. The flexibilities that are under the current grant, definitely, when we had the sessions on the COA flexibilities, the intention was first to reassure you that those flexibilities are still needed, are still required, if we are to make actually more progress or maintain the program at the way we have done now. Going forward, we will even request for more flexibilities. However, the issue of the HR and adequate support of the HR will directly impact. We can have actual commodities in country. We can have people who are actually there, and they are there. We have more than 190,000 people living with HIV, which we are unable to reach. How will we reach them? We will reach them through people. We need people to reach them. And unfortunately, most of the other partners that are supporting in the country, the element of integration is still not yet achieved. It's an area that will bring the final efficiencies. We are saying around the targets, whatever we can make now, it gives us the opportunity, if anything happens and we still get more efficiencies, and even the TRP has mentioned that in the comments, the efficiencies that we can get during the grant making, or even during the reprogramming, even before we talk of the portfolio optimization, which is actually not guaranteed in any case. We totally understand that. So let's find a way to move forward. Otherwise, we will, Madam Chair, we'll just be still, discussing around the same area, and we are not making any progress. The day has already ended, and this is the final day for us to make a breakthrough and find the solution. And I like what Job has said. Global Fund, of course, is founded on those principles. And I want to remind Job that the country's ownership is always superior to the other principles. Thank you. Emmanuel is here with the updated calculation.
Anthony, if you don't mind, can I email it to you? Or bring the flash. Ladies and gentlemen, we just made a small change on the target for the TB, but that's also as well subject to review.
maybe as they're setting up, I don't know, any comment from participants in the room?
Solutions.
Any reaction? Yes,
Madam Chair, I
You
think
are set?
the big man would like to say something.
yes, Blaise.
I think, Madam Chair, I think we have really to make a bold decision to move, because there will be talking and talking. People will be talking and talking. To find 4.8 million, it can't, even if you review the program management. By the way, this program management, if you take the percentage of it, it's small compared to other program management. So even if you take, you reduce, you will not reach 4.8 million. So the only option remaining is revisit the target. So the country team need to come clear about it. Let's revisit the target. Let's agree or disagree on the target that are proposed by the team here, and propose.
Thank you.
But otherwise, there is no other way.
Thank you, Blaise. Let's listen to Emmanuel, and then I think we have already indicated our, direction of where this discussion is going to go. That at this stage we are going
Anthony,
to
you
look at
ready?
the targets. So let Emmanuel just share.
Anthony, you ready?
Update it, and then we'll try to see, if that's how we are going to work around that.
All right, Anthony, go to
Unless
slide
someone
number
has a-
7. Thank you. Ladies and gentlemen, sorry that I did not actually include that one because I was looking over at a more gradual reduction of everything else. Now, as you go, if you had read the HPMT document by the TB program, the targets for second line, the targets for the MDR TB was put in as per, which was, the grant contribution, the Global Fund TB grant contribution. The targets were put in at an increment of 33% for 2021, 45% for 2022, and 67% for 2023. And these are very ambitious targets that they had put in of 120 for 2021. It will jump up by, and 120 is actually an increase of 33% from projected year, which is this year, okay? And if you looked at the previous target, by June, it was by June 2020, we had about 37 people on treatment. So if we're going on the same thing, we'll say about 70 odd people to be on treatment. Going forward, if that's the target that's put in, so from about 70 on treatment to about 120, which is a very, very high amount, even higher than the 33% that they wanted. Next is the 193, which is 45% increase. And next is the 67% increase, which is 349. Yes, we have challenges, and we still have a lot of things to do to get to that, and including even operationalization of some of our programs. Next. Going by the targets that we have, like I said, by the end of this year, we should have about maybe 70 odd people under treatment. If we were to put about 33%, and we can come to a target of about 100 instead of 120, okay? With the same target increase percentage, which they actually gave us of 45%, if we add it to 100, by the end of 2022, we should be having 145 people under treatment. Next, after that, by the end of, sorry, that's supposed to be 2023. I'm sorry about that. Yeah, it's supposed to be 2023. We should be having now 242 people in treatment, minimum of course. That's the minimum target we have. And of course, we can actually go up. Next target. Next slide. Now, the decrease in MDR is in line with the percentages given by the NSP. That's what I've said over there. The total number on treatment over the period of 3 years will be 487 people instead of 662 over the life of the from 2021 to 2023. Now, this is about 26% reduction in the number of people who will be under treatment. Now, if we're going to run on a gross percentage next, that's the MDR budget. based on 662 patients enrolled over the 3 years. It comes to 3,767,561. That is as per the details were given by MISO this morning. A reduction of about 26% in that one, that's just a gross reduction, will bring it to about 2,787,995,000. The gross savings achieved will be about 980,000. Now, can I please give a caveat on this one as well? And please, it's an estimate, but please note on this aspect. While we may be having a saving of this amount, earlier on I had indicated that there will be a bigger saving. There's a saving from the change of medicines. By reducing this amount of patients, we'll actually reduce also the number of medicines we'll have to procure. So please keep in mind that the other finer detail in the, if you go 2 slides ahead, Anthony. If we continue with the same program, okay, if we continue with the same program and say we also make a reduction and make the changes of using using bedaquiline instead of delaminide, on top of the savings we get by reducing the targets of the TB, we can still actually get a lot more savings coming out. It may be, give or take, even more than $1 million. Now, we have not calculated that one, please, so let's just use this as an estimate of about 900,000. If we use this estimate of 900,000 and combining the savings we've made, 900,000 plus 900,000 plus about 2.4 million, we'll be looking at about 4.2 million in potential savings. Technically, if we go now further down in details, we can actually achieve more than that 4.2. And the target I'd given earlier was about 4.1 saving if we do estimates. This will now actually require the PSM and other people to sit down properly. Thank you.
Thank you, Emmanuel. To conclude on this, Chair, this is what we have done during, and you know very well, during our consultation. And I want to get back to the country team. At this point, if we combine everything, as he said, in fact, the gap remaining will be around 500,000. You remember I said earlier on, there is still, even if we revisit the targets at this point, which we regard is now the last resort, because we are already at the best efforts that we have been making. We say that the remaining gap will still look back to the PR, and if it is 500, I believe the PR will have no logic to tell us that they cannot find within all the modules that are there. So we are saying, Madam Chair and Job on the other side, please, we actually need to move forward here. The options that we have require that we make tough decisions. So whatever options that are there for the PR to revisit are still there, and in order to fill the final gap that is reflected, to me, if we do the details, actually it's coming to be around 500,000. The final gap is based on all the submissions that we are making at this point. This is what I want to say, Madam Chair, and I stop here. Thank you.
Thank you, Dr. Kidian and Emmanuel, for that. And I think this is very, very clear. At least we can see, some significant savings that we can make, we could make from looking into this. So, Job, I think from the country team, this is the recommendation I think we are making from this side for us to be able to move forward. And we would like also to hear from you if you have, a different suggestions or, areas that we can look at. And even the LFA is here. Maybe we can also hear from Samson if you have other recommendations that you will make. Otherwise, we are recommending that the PR will go and look at this and try to work in this line.
Thank you, Madam Chair, and thank you, Emmanuel and the team, for coming up with the proposal. As I said, it's an option, and it's a very welcome proposal, and we adopt it. The only caveat I give is that the HR costs, and you have to kindly bear with me on that, the HR costs that we've been incurring in this grant, in as much as we know they are only specific to this grant, we do not look forward to having them increased beyond what they are for the next implementation period without a very strong justification. And this is mainly for staff around the central level. We looked at the central level staff at all levels, including PR level. We looked at the health facility level, and it has less to do with the health facility level. The health facility level will be more interested with the rationalization to see exactly where the staff that has been proposed are and which facilities, because this discussion is something that we've already had. So we are not saying there will be major deviations, only that I'm saying if there are, we have to be very clear. If we look at the HR component and their efficiencies there, they will go to the HIV targets. This is just a common point that we need to establish. Otherwise, we are not just going to targets for the sake of it, disregarding the other component, because it's equally important. And there is a lot of detail there that we can't really exhaustively discuss here. And for the other components, we are very much in agreement. This is what I wanted to communicate.
Okay, thank you. And I mean, I agree with you as well. You know, when it comes to the HR, I mean, if it's proportional to the targets, that's well. When we are setting targets, we are setting interventions. We also look at the equivalent of HR, you know, capacity required to implement that. So we'll be looking at that all together. So thank you. Yeah.
Thank you so much. Yeah. So I think then we will have, of course, to agree on the next steps in the interest of time. Yes.
We are supposed to have. I believe that we have the other documents which are supposed to be finalized as well today. That will be, maybe we hear from Blaise on the update on that. And
thank you, Chair. I think now the ball is in our court, in mainly the court of the PR, LFA, and country team. I think the CCM has provided clear guidance. Let me repeat the targets again, so we are on the same page, because this will influence the budget. And there is a lot to do, because we have to recalculate everything now. So for HIV, IRT, 2021 is 47,000. 2022, 53,000. 2023, 59,000. Those are the targets that are agreed here. For MDR-TB, 2021, 100. 2022, 145, and 2023, 242. Those are the targets that are agreed. Thank you very much, Emmanuel, for the great work. Yes, so there is a lot to do to update the budget, the list of health products, the PF. There is a lot to do. So, we will sort out that. So, Madam Chair, so we'll go to work on the grant document based on the agreed targets, and LFA should sit with PR to go through the HR in details at the central level, at the PR level, central level, and the site level. So we make sure that there is no increase in the HR compared to the current grant. I mean increase in headcount, not in the budget. Thank you.
Yeah, go on.
Thank you, Dr. Blaise and Job, for all the efforts and everything, and colleagues here. I actually just want to raise an alarm here. We are happy that we have reached this level, and we know there are still efforts to be made to close the remaining gap. However, I would not want or I want to advise that as the PR works on the HR with the LFA, please, whatever little time you have, let the process be consultative as well. I'm saying this, you all know that I was in the Ministry of Health. I was doing much of this under the current grant, and I know what is there, and I know what has been achieved and what has not been achieved in terms of the transition plan. And I also know the sensitivity and the need for the HR support. Current grant is scaling up. Current grant has included activities, new modules. So also let's be mindful of that. I'm not saying anything at this point, but I'm just recommending any discussion or any efforts that are being made by the PR. I know the ball is now placed on your side with the LFA and the country team, but please let it be consultative. Otherwise, it will come and drag us back again. We are very much aware that we need to achieve efficiencies, and the grant or global fund is a performance-based investment. All those principles as outlined by Job earlier. But let's also not forget the lessons learned as we move from where we were up to where we are today. So, Madam Chair, that's what I want to suggest. The second thing regarding the way forward, we may need to break at this point, but as we said yesterday, the final document and the final presentation, the major issue now is actually the final PF, in terms of the targets, which are actually the ones that are being revisited, as well as the budget, the detailed budget and the final budget. That needs to be shared with the plenary tomorrow. So we need to agree. And the PR should also tell us what time they will be ready for that tomorrow. Whether it is in the morning, whether it is after lunch, or just after the tea break like the other time. We need to know that from Dr. Blaise, so that we reconvene tomorrow, and we know that is the final day. So, back to you, Madam Chair.
Thank you, Dr. Kidan, and thank you for stressing on that. And I think in regards to the HR, Dr. Blaise also has said the revision is going to look really at not necessarily adding, new positions, but try to review what we currently have. And it's important that this is done in consultation with the CCM. I believe CCM and the Ministry of Health
senior management
as well, senior management of the ministry.
SAC is here, so.
Yeah, and SAC is here. So if they can work on these, and then hopefully tomorrow, since we are all here, that can be shared as well. Dr. Blaise, are you?
When do you think the final version will be ready tomorrow, so that we reconvene? We decide the time we are reconvening. Can we reconvene? Our 10 is okay with it.
No, Hirasha will not be. We go to Arba, Talata, in the evening, right? They will not finish. Next week. No, 1 hour.
Samson, Yeah, consultation among you and the PR. What time are you giving us to reconvene tomorrow?
Well, I think the big question at the end is, and I think we discussed this, is the budget cannot continue without the new PSM quantification. So what time will the PSM quantification be finalized so that it can be incorporated into the budget because of those new targets? That is the critical component.
Unless we finish the consultation in country.
Is 10 okay with you or not? We'll continue at 11, but then we will give these people the information before that. That's what it means.
It means we start by 8.
Can we start after that?
Let's do 11. Let's do 11, yeah.
So,
Please, colleagues,
are we wrapping up,
yeah.
Chair? Are we finishing it up
No,
now?
colleagues, give us just one.
Yes, Madam Chair.
Have a minute.
Actually, the PR and LFA, by all means, they will have to finish the task that is given to them, and let us reconvene at 11 tomorrow. Yeah. Because the consultation is going on, and there's no clarity as to what time things will be ready. But we also need to give them, a cut-off time, that by this time they should be ready. So it's either we tell them by 11, or if they think that things are still difficult for them, let's reconvene after lunch. Yes, from 2.
Yeah, I think.
Yeah, Dr. Blaze will give you enough time. Let's reconvene after lunch at 2.
He doesn't even look.
Okay, you have it. Thank you, Madam Chair, because we will have to have a
Thank you,
decision
and thank
here.
you, PR team. Job and the team online, I think we will try to. Yes, raise his hand. So I think we'll close here and then allow the PR and the LFA to continue, look at the document again with these recommendations, and we are proposing to find some time tomorrow, either in the morning or after lunch, I think. Well, okay, let's do it after lunch at 3. 3. At 3. To allow them enough time. I mean, we don't want to cut, we do the closing and we finish once. There will be, it's Saturday anyway. It's a Saturday, so people will be logging in from their houses. Yeah. So thank you, country team. Thank you, Job, and thank you, team online.
Thank you very much, Madam Chair. Thank you, everybody. So we will convene tomorrow.
Tomorrow,
to
yes.
finalize everything.
Yes, thank you.
Right.
Thank you. Okay.
Good evening, everybody.
You
Bye.
too. You too. Bye-bye.
Thanks, guys.